Cystic fibrosis. A presentation by Haley Turry, Tamara Havers, and Annie Kivany. Cystic fibrosis, or CF, is a genetic disease which targets the digestive and respiratory systems. It is characterized by pancreatic cysts, where the cystic comes from, and excessive fibrous connective tissues, where the fibrosis comes from. The disease prevails in northern European countries. It affects roughly 1 in every 4,000 U.S. citizens and approximately 1 in every 3,600 Canadians. People inherit cystic fibrosis in an autosomal recessive fashion. This means that if you get a mutated copy of the disease-associated gene, known as CFTR, from both of your parents, you will end up having the disease. People with only one mutated CFTR gene do not show signs and symptoms of cystic fibrosis. CFTR stands for Cystic Fibrosis Transmembrane Conductance Regulator. In a healthy individual, the protein encoded by this gene functions as a chloride ion channel, shuttling chloride in and out of the cell. The cells of CF patients have difficulty moving these anions across the membrane because their proteins are either not produced, not folded properly, or just not good at their jobs. The most common mutation in cystic fibrosis is the deletion of a phenylalanine residue at position 508. This mutation disrupts CFTR protein folding in the endoplasmic reticulum, and consequently, these proteins are not glycosylated in the Golgi apparatus and are not transported into the apical membrane of the cell where they belong. Over the years, studies performed in pigs, rodents, and humans have provided evidence that support that in addition to CFTR's role as a chloride channel, it is also an important regulator of bicarbonate transport via the Cl-HCO3 exchanger, sodium movement through the amiloride-sensitive Na+ channels, and potassium transfer via the ROMK-K+ channel. Mucus is made by mixing mucin glycoproteins with salts, lipids, free proteins, and an abundance of water. This lubricating substance is secreted by goblet cells into the respiratory tract. Healthy airways are lined with a thin layer of mucus to trap dust, debris, bacteria, and whatever else could harm the lungs. Together with the action of beating cilia on surrounding columnar epithelial cells, the intruders are forced to evacuate up a mucociliary escalator. In CF, however, this protective mechanism is defective, and we see a terrible cascade of events. Bacteria that enter the respiratory system encounter the mucus and stay trapped. Unfortunately, the thickened mucus pushes down on the cilia and depresses their function. As more and more bacteria accumulate, infection starts to set in. The bronchi are inflamed, biofilms develop, mucus builds up further, and more bacteria are drawn into the lungs. This futile cycle makes it very difficult for air to flow through, with increasingly more junk clogging up the airway. Patients with a lot of mucus buildup experience what is called CF ascorbation, a worsening of their condition marked by frequent coughing, fever, bronchiectasis, and pneumonia. Many will recognize CF only as a type of lung disease, and respiratory failure will in fact be the cause of death for many CF patients. However, the first signs and symptoms of CF arise in the pancreas and digestive tract, months and typically even years before the lungs are targeted by the disease. For example, newborn babies may pass a thick, hardened meconium due to the lack of fluids in the digestive tract. Pancreatic insufficiency is also a very common symptom in infants and toddlers with CF. Since their thick secretions block the ducts in the pancreas, they can neither secrete the enzymes required to absorb fats and proteins from the diet, nor can they secrete hormones to maintain glucose homeostasis. As a result, these children are often smaller in stature and can develop insulin-dependent diabetes. Other downfalls of CF include nasal polyps, sinus disease, liver disease, male infertility, and reduced fertility in women. The screening process to diagnose CF is very comprehensive and accurate today, thanks to our understanding of the genetic background of the disease. All newborns are screened for metabolic diseases within a few days after birth. This screening includes measuring immunoreactive trypsinogen, IRT, in blood. High levels of trypsinogen can be a sign of CF because, as we learned, CF disrupts the normal function of the pancreas, which affects the levels of enzyme it produces, one of them being trypsinogen. Positive IRT results can be confirmed by sweat chloride testing. The test quantifies Cl concentration in the sweat because if CFTR is not transferring chloride to the extracellular environment within the lungs and the pancreas, there will be a high buildup of these ions in sweat glands instead. Positive results from the sweat tests are followed by genetic testing to search for CFTR mutations. Genetic testing is used to confirm the diagnosis, but it cannot catch the most uncommon mutations, which may cause false negative diagnosis. The average lifespan for someone living with CF has gone up to 38 years. Since these patients were born, major improvements have been made in the way of treatment. While there is still no cure for CF, physicians and clinicians predict that children born nowadays with CF will live even longer. Patients today are gifted with treatment options beyond the scope of only a lung transplant, which is incredibly invasive and full of risks, such as infection, rejection, etc. Personalized medicine approaches are now employed, and medications are readily available in hospitals, clinics, and pharmacies. Currently on the market is a drug called lumacaftor, given in conjunction with another drug called ivacaftor. Lumacaftor is a chaperone protein that carries CFTR proteins to the cell membrane, even if they are misfolded. Ivacaftor is then known to help improve function in the mutated protein by increasing the fraction of time that the CFTR channels stay open. This treatment is effective in cases of CF that are caused by the phenylalanine 508 deletion. However, it fails dramatically when other mutations lead to CF. Earlier this year, Maraglia et al. Published a paper showing how amphotericin, the antifungal drug, digs ion channels in the epithelia, thus establishing chloride and bicarbonate transport in CFTR-deficient cells. This treatment option would be possible in all cases of CF because there is no dependence on the CFTR gene or protein, only a mimic of its function. The transport of chloride anions along these channels restores proper water movement, improving the consistency of mucus. The transport of bicarbonate anions, on the other hand, balances the pH of the surroundings, protecting cells from microbes and ultimately reducing bacterial infections in patients with CF. Although this is not available yet, this may be the future for CF treatment. Cystic fibrosis is a disease caused by CFTR mutations that causes the malfunction of the CFTR protein. This channel protein is present in all mucus-producing organs, and when its function is compromised, these organs produce more thick and sticky mucus that blocks secretion ducts in the pancreas, destroys ciliary function in the lungs, and serves as a good surface for infectious bacteria to adhere to and grow on. This causes problems to the digestive system and permanent lung damage. CF patients often die of respiratory failure. There are multiple ways to diagnose CF and many treatments that can improve the quality of life, but a curative treatment is yet to be found.